Just let me apologize for being a payer here, and benefits are really complex. You know, benefit design is really complex, and you can have 8 patients in your office with Blue Cross with 8 different benefit structures, and the whole thing will be funded differently. So we're working on this system to make these decisions. It's just very hard to get the information. Increasingly, what's happening with these things, which is going to make it a little bit less relevant, is as the plan design is really shifting to things that have out-of-pocket maximums. In the year that you're getting your chemotherapy, you're damn well hitting your out-of-pocket maximum.
And maybe in the first month.
Maybe in the first month. So even though it's a shock at first, if you can counsel that huge numbers of patients, it really isn't affecting their out-of-pocket. It really doesn't affect their out-of-pocket costs. If you have a $7,000 family deductible in the course of treatment of any cancer, you're going to hit it. And then when you hit your out-of-pocket maximum. So I think a lot of these issues as the benefit design, especially the private plans and those on the exchange, are going to these out-of-pocket max. I think that's going to become less of an issue.
Yeah, I hope so, because living on the other side, the benefit design is a nightmare. Going back before this modern era, even when things were less costly, the copay at each visit. So if I have a patient with HER2 positive breast cancer, and she knows and I know, and it's standard of care for her to come in every week for her Herceptin injection, and then she misses an injection because she doesn't have $50 for that week's copay. We're not helping anyone in that system. We're doing wrong by the patient, doing wrong by society. And so we often benefit design doesn't take into account the personalized aspect of medicine. It's trying to develop policies that can be broad. I'm not sure how we overcome it, but it seems to me that we need as much thought about that as thinking about all these other kind of clinical solutions. We need to find out ways to make that benefit design and operationalize it so it's less problematic.
Yeah, I mean, just really everybody's looking, they call it, quote, value-based benefit design, but to try to get benefit design in a way that patients are motivated to do the right thing for themselves is critically important. Besides having value-based benefit design that motivates them to do things that are cost-effective, I think it's incumbent on us to design benefit plans that are not going to create obstruction for patients to take that oral agent, to fill that prescription. Having people take half the dose thinking they're going to get half as much. I think it's incumbent on us as payers to try and, as we're looking at changing and moving to value-based benefit design, to just really address some of those structural issues.